Hey everyone, this is Emma. Today is Saturday, March 28th. So, today I wanted to talk to you about what nurses and doctors across the United States are experiencing right now in terms of shortages of personal protective equipment as well as just being undervalued in general. But before I get into some of the details and examples of stuff like that, I wanted to talk to you about something else that those on the front lines might be experiencing. It's called viral load. So, the verdict is still out on the impact that viral load has on people that are infected by the coronavirus, but some recent developments to me seem to be answering the big question as to why so many healthcare providers are falling ill and some are even dying. And I want to take time to point out for those that are still downplaying the severity of this virus and saying that the flu is worse. If you've seen data or examples, please feel free to show me how many healthcare workers die from influenza every year while working on the front lines. It's not something that I've come across or ever remember being something normal that I see in the news. So if I'm missing that and that does exist, please point me in that direction, send me a message, post a comment, whatever. But so right now, coronavirus is in the news constantly. We all know that. And to some extent, we only know what they tell us. So if the stories of healthcare workers dying from the flu weren't normally being put in front of our faces every year, there's actually a good chance that we wouldn't know that it were happening. Except we probably would, because one, most of us know at least one nurse or doctor, and those people are being incredibly vocal right now about what's happening and what they're experiencing. I don't know about you, but I've never come across a doctor or a nurse in my personal life that has opened up to me about how many of their colleagues are falling ill and dying from the flu. And two, Big Pharma, in their name, is very big. We hear about medications that we should be taking constantly. We hear about it on the news, we hear about it in commercials, we hear about it on YouTube, it's on the backs of buses, it's in magazines, and we tend to hear about each and every influenza death that doesn't fit the norm every year. And it's almost always coupled with a call to vaccinate. Oddly enough, even when the person who died was vaccinated, there's still usually a call to vaccinate in those news briefs. So my point is that it's not really a stretch to assume that if our doctors and our nurses were dying every year in droves from influenza, we'd probably be hearing about it along with a huge call to vaccinate the masses. But back to what viral load is and how that relates to what's happening with the coronavirus, I have a couple of articles that I want to highlight, and I'm going to read some excerpts from some of those, and then we'll kind of talk about that. So first, in New York Magazine, there's this article from March 27th titled, "Is Viral Load Why Some People Get a Mild Case of COVID-19?" As researchers try to understand why some people infected with COVID-19 experience mild or non-existent symptoms while others require hospitalization, one factor they have considered is the viral load, the amount of the virus detected in a patient. The viral load is a measure of how bright the fire is burning in an individual. Early indications suggest a correlation between the fire and the burn in COVID-19 patients. People with larger viral loads are generally getting sicker. So here we have a short interview with Dr. Alan Foxman, assistant professor of laboratory medicine and immunology at Yale School of Medicine. And there's some great questions in here that I will go over with you. What do we know about the relationship between viral load and the severity of a COVID-19 case? Dr. Foxman says, according to recent papers that came out in the past week or so, at least in 2 papers from The Lancet, which is quite a reputable medical journal, there's a correlation between high viral load and more severe symptoms. That really makes a lot of sense because viral replication is needed for a virus to cause diseases. Usually only a few viruses get in your body, and then they begin to make copies of themselves. That process of taking over cells and replicating is what leads to disease. If the virus can't replicate much, in general, they don't cause as much disease. There are also a few studies out of China and Italy that seem to indicate viral load is not a factor in severity. What do you make of them? Dr. Foxman said those studies are preprints, meaning that they have not yet undergone scientific peer review and are not officially published. For the paper from Italy, I don't think the authors are making a case for the lack of correlation of viral load with symptoms. They simply show a great degree of variability in viral load for both symptomatic and asymptomatic patients, so it's difficult to conclude anything either way. So did the Lancet studies distinguish between a viral load that is a measure of the virus's replication in a patient and the infectious dose, i.e. the patient's exposure? Yes, that is an important distinction. Viral load described in the recent papers is the amount of virus measured in a sick person's nose and throat. Someone is sick, they come to their doctor and they get a swab of their nose and throat, and the test measures how much virus is in there. Based on the Lancet studies, measuring more virus over the course of infection correlates with more symptoms and more severe disease. As far as transmitting from person to person, it makes sense that the amount of virus you are exposed to impacts how likely you are to become infected. If there's one virus on a doorknob, you're much less likely to get sick from touching the doorknob than if there's 1,000 viruses on that doorknob. With a bigger exposure, some of the viruses are more likely to actually get into your airway and find a place to replicate. If you're exposed to no virus at all, you're not going to get sick. If you're exposed to one little viral particle, you probably have a much lower chance of becoming infected than if you're right next to someone on an airplane who's coughing for 8 hours. The amount of virus needed to cause an infection is the infectious dose, which is different from the viral load. How will studying the viral load in greater depth change how we manage this virus? Dr. Foxman thinks it's very helpful. First of all, the way most people are tested right now is by putting a swab into the nasopharynx, which is the nose in the back of the upper part of the throat, and then looking for the viral genetic material. That's the gold standard test, but what's really interesting is that the test isn't necessarily positive or strong positive throughout the whole disease. That's really important to know. Just because somebody is negative on that test doesn't mean they don't have the disease. We're making a lot of decisions on how to care for people, whether they should self-isolate, all of these things, based on that test. It's very important to figure out not only the viral load, but even how well these tests work to categorize somebody as having the disease. Studies showing that viral load correlates with severity of disease make sense in terms of what we know about other viruses. My laboratory studies respiratory viruses, and it makes me think that a lot of the rules about other respiratory viruses may also apply to this one. It really helps in thinking about how to approach it from a research standpoint. What it says to me is if the virus can be controlled and cleared when it's still in the nose and throat, you are going to have a more mild case. I wouldn't say it's 100%, but what it says to me is that this virus infects the nose and throat. And if the local mechanisms to get rid of the virus are really effective and don't let the viral load get too high, then that person is on the pathway to a more mild disease. Whereas if this virus is able to grow a whole bunch and really replicate to a high level in the nose and throat, you have a much higher chance of inhaling it into your lungs where the virus could set up shop. Now I wanted to take a moment to point out here something that this doctor and this article are not communicating, but I thought of it when I was reading this, where it says that the virus infects the nose and the throat. And if local mechanisms can get rid of the virus before it can get down into your lungs, well, that would obviously be a good thing. Weeks ago, I started seeing suggestions from some medical professionals, but specifically people from other countries who culturally use more homeopathic remedies and things like that than we do here in the United States. And there was a whole list of tips that are just kind of general tips to get you healthy, but one of them was to sip water a certain number of times a day to clear your throat in case you did happen to come in contact with the virus and it's inside of you. Now, I don't know if scientifically just drinking water works to clear a virus in that way, but I found it very interesting that I kept seeing that repeated more and more, and now I'm seeing a lot of fact checkers respond to those claims, spending a lot of time attacking them. So I just wanted to point that out real quick. Here on one of the WHO's websites, where they're pointing out things that are fact or fiction, one thing on here lists water. Does drinking lots of water every 15 minutes flush out the new coronavirus and protect against COVID-19? Fact. There is no evidence that drinking lots of water flushes out the new coronavirus. However, for good health in general, it is recommended that people should have adequate water every day for good health and to prevent dehydration. So honestly, the WHO's response here is kind of the least crazy one that I've seen. But I'm seeing actual fact checkers that work with websites like Facebook attacking this claim that drinking water can help the virus go away. So here's factcheck.org. Here's an example of something that was spreading around the internet, and they have a quote from someone that says, "You're not rinsing it away so it doesn't go to your lungs." They say right down here, factcheck.org is one of the several organizations working with Facebook to debunk misinformation. Then over here we've got Africa Check, also checked the same thing. And there's many, 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 many more where these came from. But going back to what the WHO said it's good for health in general to have water. We all know that. And the fact that fact checkers are spending time trying to debunk the idea that you can drink water every 15 minutes or so to flush your throat of the virus is pretty maddening to me. Even if it's not true that happens, we know that it's good to drink water. There are so many things floating around the internet right now that are terrible and wrong, and I don't see why they have to spend their energy on this. And as I've mentioned in some other videos, I have personal experience with fact checkers going way too far and causing huge problems for businesses that exist on Facebook. One of the outlets that I work with gets fact-checked sometimes, and we've been fact-checked by Africa Check, which confused me at first because the article had absolutely nothing to do with Africa. They're supposed to primarily work on issues surrounding Africa, but they branch out and do some other things too. We're constantly fact-checked for things that we shouldn't be. We're not saying something that's not true. We're not saying something wrong. It just doesn't fit the narrative that they want to be spreading on a place like Facebook. I know that Africa Check and factcheck.org have harmed pages and profiles on Facebook for sharing information suggesting people drink water. Maybe if people were suggesting to drink bleach or doing something harmful, or somebody was trying to sell sips of water, it would be worth taking the time to address this. But it's just goofy to me that that's even happening. But sorry, that's a huge tangent. So I want to take you to this other article in the New Yorker. How does the coronavirus behave inside a patient? This is a March 26th article. And I'm not going to go over the whole thing because this is really long, but I think this article is great, so I recommend that you take a look at it. It gives a really interesting history in the beginning of inoculation and how that was used before it turned into vaccination, how it was used in smallpox with taking a little bit from the pox and injecting it into somebody else. It was incredibly interesting, and I learned some things that I didn't know about how those things work. So this article asks some questions that are important, saying that they can change the way that we isolate, treat, and manage coronavirus patients. First, what can we learn about the dose-response curve for the initial infection? Can we quantify the increase in the risk of infection as people are exposed to higher doses of the virus? Second, is there a relationship between that initial dose of virus and the severity of the disease? That is, does more exposure result in graver illness? And third, are there quantitative measures of how the virus behaves in infected patients that predicts the severity of their illness and how infectious they are to others? So far, in the early phases of the COVID-19 pandemic, we've been measuring the spread of the virus across people. As the pace of the pandemic escalates, we also need to start measuring the virus within people. What we've learned about other viruses, including the ones that cause AIDS, SARS, and smallpox, suggests a more complex view of the disease, its rate of progression, and strategies for containment. In the 1990s, as researchers learned to measure how much HIV was in a patient's blood, a distinct pattern emerged. After an infection, the virus count in the blood would rise to a zenith known as peak viremia, and patients with the highest peak viremia typically became sicker sooner. They were least able to resist the virus. Even more predictive than the peak viral load was the so-called set point, the level at which someone's virus count settled after its initial peak. It represented a dynamic equilibrium that was reached between the virus and its human host. People with a high set point tended to progress more rapidly to AIDS. People with a low set point frequently proved to be slow progressors. The viral load, a continuum, not a binary value, helped predict the nature, course, and transmissibility of the disease. To be sure, every virus has its own personality, and HIV has traits that make viral load especially revealing. It causes a chronic infection, and one that specifically targets cells of the immune system. Yet similar patterns have been observed with other viruses. And immunologically, that's not surprising. If your system is able to combat viral replication with some efficiency, owing to your age, your genetics, and other indices of immune competence, you'll have a lower set point. Could a lower initial exposure also lead to a lower set point? Faced with a smaller challenge, the immune system could have a greater chance of controlling the pathogen. In contrast, if you're inundated with multiple high-dose exposures, the swiftly replicating invader could gain ground that the immune system might be hard-pressed to reconquer. That brings me to the question, is that what we're seeing with frontline healthcare workers? They are inundated daily with high-dose exposures because they're intubating people. They're in rooms that are just full of the virus, and it's on their clothes, it's on their masks, it's on their skin, and we know that they're having a hard time getting the masks that they need right now. So a lot of them are being overexposed and exposed probably more than they should be right now. So does a larger viral dose result in more severe disease? It's impossible to erase from one's memory the image of Li Wenliang, the 33-year-old Chinese ophthalmologist who sounded the alarm on the first COVID-19 cases. In his final illness, a photograph shows him crimson-faced, sweating, and struggling to breathe in a face mask shortly before his death. And then the article goes on to highlight some other cases of doctors that died in China. Could the striking severity of their disease be correlated with the amount of virus to which they were initially exposed? At least 2 ER doctors in the United States, both on the front lines of the pandemic, have also fallen critically ill. To go by available data from Wuhan in Italy, healthcare workers don't necessarily have a higher fatality rate, but do they suffer disproportionately from the most severe forms of the disease? An infection disease specialist and vaccine scientist said, but for reasons that we don't understand, frontline healthcare workers are at a great risk for serious illness despite their younger age. Some suggestive research has been done with other viruses. Mice who were given higher doses of certain influenza viruses developed a more severe form of the disease. Yet the degree of correlation between dose and disease severity varied widely from one strain of the flu to the next. What sparse evidence we have about coronaviruses suggests that they may follow the pattern seen in influenza. In a 2004 study of the coronaviruses that caused SARS, a team from Hong Kong found that a higher initial load of viruses measured in the nasopharynx, the cavity in the deep part of your throat above your palate, was correlated with a more severe respiratory illness. Nearly all the SARS patients who came in initially with a low or undetectable level of virus in the nasopharynx were found at a 2-month follow-up to be still alive. Those with the highest level had a 20 to 40% mortality rate. This pattern held true regardless of a patient's age, underlying conditions, and the like. Research into another acute viral illness reached a similar conclusion. The more virus you had at the start, the more likely you were to die. Harvard virologist and immunologist Dan Baruch believes that there may be a correlation between the initial dose of the virus and the amount of virus in lung secretions at a later time. He said logically, the larger amount of virus should trigger more severe disease by prompting a brisker inflammatory response, but that's still speculative. The relationship between initial viral dose and severity remains to be seen. And this is something that I found very interesting because there has been some discussion about the accuracy of the swabs and the different kinds of tests and false negatives, false positives. And here it says that the problem with measuring viral loads in a swab is that it is affected by pre-analytic factors, such as the way in which the swab is taken. Oral swabs are notoriously affected by small variations in how they're done. So a correlation with severe disease may well be true for the viral load in blood. In a paper published in the Lancet Infectious Diseases in March, researchers at the University of Hong Kong and Nanchang University reported that viral loads in nasopharyngeal swabs from a group of patients with severe COVID-19 were 60 times higher on average than the loads among patients with a mild form of the disease. So as the virus continues to cyclone across the world, will we begin to find quantitative answers to these questions of how exposure, intensity, and subsequent viral loads relate to the clinical course of COVID-19? How will these insights change the way we manage patients, hospitals, and populations? Start with the relationship between exposure, intensity, and infection. Think for a moment of how we monitor those who work with radiation. We set limits on someone's total exposure to radiation. We already know how critical it is for doctors and nurses to limit exposure to coronavirus by using protective equipment. But for healthcare workers on the front lines of the COVID-19 pandemic, especially in places where protective equipment is scarce, like the United States, we might also want to keep track of total exposure and put limits on how much exposure someone can have. Establishing a relationship between dose and disease severity could in turn affect patient care. If we could identify pre-symptomatic patients who were likely exposed to the highest doses of viruses, we might predict a more severe experience of the disease and give them priority when it came to limited medical resources. If anything, it seems obvious now that we should prioritize testing, at least testing healthcare workers who are exposed to a higher viral load, even if this ends up not being true and there's nothing to this. So while the jury is still out on how exactly the viral load works with this coronavirus, it's probably safe to assume that the higher the viral load, the worse the illness will be. One, because that happens with other illnesses, as previously mentioned from this article in the New Yorker, and two, we are seeing many doctors and nurses not only infected, but also dying. So if we go with that assumption, that should mean that we need to protect frontline healthcare workers more, especially more than we are. We're doing a horrible job at it. Unfortunately, we had ample warning that something like this might someday occur, and we didn't do anything about it. So it seems like it must have been easier to spend a bunch of time and money on pandemic simulations and preparedness and write a nice little report about it and stick it on the shelf than it was to actually learn something from those and then be prepared. So now we're here, and we're clearly not prepared. Here's an article in Politico. Trump team failed to follow NSC's pandemic playbook. Oops. Right, this is from March 25th. The Trump administration, state officials, and even individual hospital workers are now racing against each other to get the necessary masks, gloves, and other safety equipment to fight coronavirus, a scramble that hospitals and doctors say has come too late and left them at risk. But according to a previously unrevealed White House playbook, the government should have begun a federal-wide effort to procure that personal protective equipment at least 2 months ago. Is there sufficient personal protective equipment for healthcare workers who are providing medical care? The playbook instructs its readers as one early decision that officials should address when facing a potential pandemic. If yes, what are the triggers to signal exhaustion of supplies? Are additional supplies available? If no, should the Strategic National Stockpile release PPE to states? Probably should have. The strategies are among hundreds of tactics and key policy decisions laid out in a 69-page National Security Council playbook on fighting pandemics. Each section of this playbook includes specific questions that should be asked and decisions that should be made at multiple levels. Within the national security apparatus, the playbook urges repeatedly advising officials to question the numbers on viral spread, ensure appropriate diagnostic capacity, and check on the U.S. stockpile of emergency resources. And if you're interested, that entire playbook is right here, and you can read through all of it. Although honestly, I might suggest that you not look at it, because you might end up getting really, really, really mad. We have had enough time and countless warnings about how to be prepared for something like this, and we have completely dropped the ball multiple times in multiple areas, and people are suffering now for it. So in case you've somehow missed what nurses and doctors have been experiencing, I would like to walk you through some of it. Let's start with this Twitter thread that asks a very important question. And I'm not going to go through the whole thread with you, but I will link this in the comments on YouTube because I think it's a really good thread to read. It's the day in the life of an ER doctor. It goes through when he wakes up, what work is like. It's calm on the morning city streets, but then he goes into the building. There's coughing, there's all kinds of sounds, and basically everything is non-stop through all the rest of these tweets. By late afternoon, you need to eat. Sometime in the afternoon, you recognize that you haven't drank any water. You walk out and take off your mask. You feel naked and exposed. It's still raining, but you want to walk home. Feel safer than the subway or bus. Plus, you need to decompress. The streets are empty. This feels nothing like what is happening inside. Maybe people don't know? Exactly. Maybe people don't know. Unfortunately, some people don't know. And some of these people think that this whole entire thing is fake. So I just want to say, you cannot trust the CDC, and you cannot trust the WHO, and you cannot trust the actions of our government and other governments, and you can even think that this is a false flag, but still believe that the virus is real, that people are sick, and that people are dying. Perhaps the people who don't think that this is real haven't ever talked to a nurse or a doctor that are experiencing this. I don't really know what's stopping them from understanding what's going on, but I'm glad that I can personally hear from doctors and nurses and people that I know that know what's happening because they see it every day. They're immersed in it, and it's true. The city streets are empty. You might not see it happening out on the city streets, but it seems to be a totally different world inside of all of these medical facilities. So the longer this goes on, more and more doctors and nurses are speaking out, either publicly or anonymously. A lot of them can't keep quiet anymore, and I don't think that they should keep quiet. But unfortunately, as in this next example that I'm going to show you, some of them are actually being punished for it. So here's an article in the Seattle Times, and you may remember this ER doctor who criticized Bellingham Hospital's coronavirus precautions. He has now, unfortunately, been fired. An emergency room physician who publicly decried what he called a lack of protective measures against the novel coronavirus at his workplace has been fired. Ming Lin, who worked at the hospital for 17 years, was informed of his termination as he was preparing for a shift at the hospital on Friday. I got a message that said your shift has been covered. He phoned a supervisor and was told, "You've been terminated." Lin said supervisors threatened his employment more than a week ago after he spoke to reporters and made social media posts accusing Peace Health of a lack of urgency to protect healthcare workers from the virus. Lin said he was told to take down his social media posts about the hospital, but refused. So let's continue with some more examples of what healthcare workers are experiencing right now. You might remember this photo that went fairly viral. Nurses at Mount Sinai West are being forced to wear trash bags due to the lack of protective gear there. Well, unfortunately, this worker at a New York City hospital where nurses wear trash bags as protection died from coronavirus. The shortage of safety gear at one Manhattan hospital is so dire that desperate nurses have resorted to wearing trash bags. And some blame the situation for the coronavirus death of a beloved colleague. One nurse said that he didn't deserve this. The hospital should be held responsible. The hospital killed him. Doctors and nurses scared to come to work to treat coronavirus patients because of supply shortages. Doctors and nurses on the front lines of the fight against the coronavirus in the United States say it's the first time they've been scared to go to work. With a shortage of personal protective equipment, some have resorted to using bandanas to cover their faces. One doctor said it's the first time we've ever been truly scared to come to work. But despite being scared, we are trained to save lives and we're committed to doing that. The doctor went on to say, "I'm embarrassed to say, but prior to this, my husband and I had never gotten around to writing a will. But this weekend, that became one of our to-do list items." And that is something that there is not a shortage of articles about. Doctors and nurses are writing their wills in droves because they know that they might get sick. And if they do, they might die. The fact that we've put healthcare workers in this position and left them feeling like there's a big chance that they might die is disturbing. Here's a tweet from March 21st from Wendell Porter. Now, Wendell, this is interesting. He is the former vice president of Cigna. He's a whistleblower and reformed insurance propagandist. He said, "I just got off the phone with doctors in Bergen County, New Jersey, who told me their hospitals are saying doctors and nurses will be disciplined for wearing protective gear, including masks. Hospital physicians tell me this is happening across the state. Nurses worry that they could be fired if they wear protective gear, but worry if they don't, they're putting themselves and patients at risk. I've heard other hospitals nationwide are enforcing this policy too. Who knows how rampant it is? Some internal documents we obtained suggest certain federal restrictions by the CDC may be guiding this decision." Folks have been asking for the explanation for this decision. We've been told that the hospital administrators are concerned patients and visitors would be unduly alarmed and fearful if they saw healthcare workers wearing protective clothing and masks. This is a photo of an anesthesiologist who ran out of PPE at his hospital. In order to safely intubate a COVID-19 patient, he had to jerry-rig his own gear. He put on a cannula. He then put on a regular old plastic bag over his head with a seal. As you can see, he taped it tightly around his neck. He had oxygen going through. He sampled his CO2 to monitor. He did this for 10 minutes, long enough just to intubate a patient. This is what we have to do because we have no PPE. I am horrified. I cannot even begin to know if this is safe and cannot recommend it. But sure, we'll be safe with bandanas, scarves, and homemade cloth masks. Here's a March 27th article in CNN. Healthcare workers on front lines feel like lambs to the slaughterhouse. An anesthesiologist in Arizona turned to eBay for N95 masks. A nurse in Ohio said she and her colleagues are forbidden from wearing any masks for fear that it would spread anxiety. A nursing home employee in Arkansas who developed a fever said she couldn't get tested. The scarcity of equipment is at a critical stage where medical workers are being asked to do something that weeks ago would have brought reprimand or even termination: reuse supplies. And it's interesting here that they say that reusing supplies would have brought reprimand or termination before. But now, nurses and doctors are being threatened with reprimand or termination for wearing their own masks or wearing something different. This system is doomed. Doctors, nurses sound off an NBC News coronavirus survey. A hospital nurse in Michigan says she and her colleagues have discussed bringing in bleach to make their own disinfectant wipes. A pregnant nurse in Ohio says she has no choice but to tend to critically ill patients without a specialized N95 mask. And a healthcare worker in Georgia has resorted to scouring local hardware stores in an effort to secure the protective masks. These are just some of the stories told to NBC News by more than 250 healthcare providers on the front lines of the coronavirus pandemic, including many who work in major hospitals. Nearly all who responded said there were shortages of PPE in the hospitals, outpatient clinics, and offices where they worked. Many reported being forced to ration or reuse supplies, including surgical and N95 masks, for fear of running out. Many also said they were facing shortages of basic sanitary supplies, including hand sanitizer and disinfectant wipes. Now, how is it that when hospitals don't seem to have any of these things and don't have large supplies of them, how did tech companies get so many of these medical masks to donate? You may have noticed in the last couple of weeks there have been some news stories about Apple and about Facebook donating millions of masks. Vice President Mike Pence announced that Apple CEO Tim Cook had promised that Apple would donate 9 million medical masks. Pence said at this moment in time, Apple went to their storehouses and is donating 9 million N95 masks to healthcare facilities all across the country and to the national stockpile. Why did Apple have 9 million N95 masks when our hospitals don't? Apple is offering the largest in a series of donations from tech companies, with Facebook CEO Mark Zuckerberg donating 720,000 masks and Tesla and SpaceX CEO Elon Musk donating 250,000. They say large employers want to be prepared when something like air quality goes beyond the level they'd be required to give the masks. It's a matter of having something you know you might need and obtaining enough of it to be ready for an emergency. But why were hospitals not thinking the same way? Why was the public health system not thinking the same way and having a stockpile for the people who will truly need it, not just people who need to go to work when there's a wildfire for a tech company? On March 24th, The Intercept published an article called "Kaiser Permanente Threatened to Fire Nurses Treating COVID-19 Patients for Wearing Their Own Masks," unions say. Nurses at Kaiser Permanente hospitals and clinics in California could be fired immediately for wearing their own face masks, according to unions representing nurses at the facilities. The news comes after nurses were ordered to reuse disposable protective gear to save supplies in the face of shortages brought on by the coronavirus pandemic. Kaiser has told nurses that if they're seen wearing their personal N95 masks, they could be fired on the spot for insubordination. Healthcare workers, at any time, but especially right now when we are battling a global pandemic, are not dispensable, and they should not be treated like they are dispensable. But that's the message that is being sent to them in each of these cases where they are not being provided what they need, when they are being told to reuse things in a way that might make them sick as well as compromise the patients around them, when they're being told that they could be fired for doing something that will keep them safer and healthier, which is better for not only them, but for the entire health system in the long run. They are not dispensable. And unfortunately, we're losing them every day. And if it continues like this, we might even lose more, because some might just walk away from this, and I wouldn't blame them at all. So what can we do? How can we support them? Because now is the time to support healthcare workers in your local area and all over the country. And I want to give you an example of some of the things that have been done. So here we have an example of a fundraiser for personal protective equipment. This was started by a nurse who was seeking to raise $2,000, but blew past that goal and has raised so far $5,000. And with that money, she was able to order 280 hospital-approved N95 masks. If you see a fundraiser like this and you can, please donate towards it. But don't wait for a nurse to create fundraisers like this. If you know nurses or doctors, or even if you don't and you have a way to reach out to some in your community and you know that something like this would be helpful, start a fundraiser for them or see what you can do to help them. The nurses and doctors who are working on the front lines right now also shouldn't be the ones that are responsible for filling this need. They're already overloaded. They're already low on sleep. So if you can help contribute to a fundraiser or start a fundraiser, please do. And if you hear about something like this happening in your area, where nurses or doctors are being told that they cannot wear a certain kind of mask and they're not given an adequate alternative, or they're being threatened, their jobs are being threatened, if this is happening in your community, rally your community to support these frontline healthcare workers. Get your community to contact the hospital that they work at or the clinic in your community that are making these decisions. Encourage a public outcry so that these frontline healthcare workers that are supporting your family and your neighbors, so that you can get the hospitals and the clinics who are making these terrible decisions to respond. Put pressure on them. Support the healthcare workers in your area if things like this are happening around you. You don't need to know a nurse or a doctor to do that, but if you get wind of it, we can all do something about that. The community can respond and can demand better conditions for the frontline healthcare workers. And you can also keep an eye out for things like this. This just popped up in Michigan on the government's website. So look and see if your community has a website like this. There's an area here for medical volunteers, for public health volunteers, for community volunteers, for donations, and where to donate blood. All of these things are needed right now. Healthcare workers are incredibly stressed right now, not only in the big cities and the epicenters like New York City and like Washington. All across the country, there's added stress, there's added worry. Smaller hospitals don't have the capacity to deal with a massive influx of patients. So even if there might not be a big concentration of infected cases near you, the clinic and the hospital systems don't have the capacity to deal with large volumes. So even a few cases might be stressing them already. They're lower on masks, they're lower on ventilators in this area. It's really, really important to be aware of what is happening in your own community and to find out how you can support these people. If you can help get handmade masks to them, if you can donate to a fundraiser to get them personal protective equipment, if you can pressure hospitals and clinics to give them what they need and to not reprimand them for keeping themselves safe. If you can cook a meal for them, if you can help with childcare, and I know those things are harder because we're supposed to be social distancing and self-isolating, but there might be an area that you can help with. Please just remember what these frontline healthcare workers are dealing with and the emotional and physical toll that it's taking on them also. Healthcare workers are not dispensable, and they need our support right now. So look into your community and find out how you can help them. Thanks guys for watching this video. Please share it. If you're watching this on YouTube, please give it a thumbs up and make sure you subscribe to my channel. And I will include a bunch of the links to stuff I talked about in the description below.